I'm going to cover a topic today called diabetes, specifically diabetes mellitus. Now, it should take me a couple of days to cover this, but I only have about 90 minutes, so I'm only going to cover type 1 of diabetes mellitus. Here's a simple concept map to show you where I'm going. So diabetes has different types, different groups. So diabetes insipidus is an abnormality of the expression of vasopressin or how vasopressin reacts on the kidney. Either case, you're going to have increased thirst and increased production of urine. Vasopressin is a hormone that is secreted from the hypothalamus. We're going to talk about the one that's to the right of this concept map called diabetes mellitus. It also belongs in the endocrine chapter, but this hormone is produced by the insulin, and this hormone, by the pancreas, and this hormone is called insulin. Diabetes mellitus is a disorder where the individual has extremely high levels of glucose in their blood. Now, under this category, we have type 1, the one that we will discuss today, type 2, gestational diabetes, and others. Type 1 is characteristic of no insulin produced at all, a syndrome called insulinopenia. Now, type 2 also has insulinopenia, which is, but instead of it being no insulin, it's just low production of insulin. And also under type 2, you have where the receptor is not binding the insulin for some reason, but that person has the right amount of insulin. So this is how you can traditionally draw a concept map looking at diabetes. Now, what I'm going to cover first is what is right, the normal process of getting glucose into the cell and making energy. So what is normal? What is the normal physiologic function? How is energy produced? Glucose comes in to the cytoplasm. It is immediately broken down by 10 enzymatic steps into pyruvate. That's called glycolysis. And then you have the rest of the cellular respiration, where you end up producing 36 to 38 ATP molecules. Glucose itself is too large to just simply diffuse across the membrane. Glucose is also polar. If you look at the glucose molecule in the right image, it is the red hexagon structure. It has to bind to a carrier protein that will then transport it across the cell membrane into the cytoplasm. This is a coupled reaction to an active transport, primary active transport complex called the sodium-potassium pump. So normally, two transporters are going to move glucose into the cell. One type is the SGLT, which stands for sodium glucose cotransporter. So like I mentioned before, it involves a sodium potassium pump. Sodium is going to be pumped outside of the cell membrane to an area of higher concentration. Then sodium will flow down the gradient back into the cytoplasm through a secondary active transport called the SGL cotransporter. As sodium flows down its gradient, glucose is going to hitchhike a ride into the cell. That is one type of movement, normal movement for glucose. Another type of movement is through what is called the glucose transporter, or GLUT. This is where the glucose molecule is going to be carried across. So if you look at the image to the right, we have a glucose, a GLUT two that is carrying glucose from the cell into the capillary. Either case, these transporters are going to move glucose. So SGLT is a 14 transmembrane helical structure, whereas GLUT is a 12 membrane spanning helical structure. So the helical structure looks like in the picture to the left, I'm pointing to a transmembrane protein, which looks like a helix. So the GLUT transporter would have 12 of those. So if you look to the right, I'm pointing to the GLUT transporter. It is 12 motifs that form this transporter. We are only going to talk about the GLUT transporter, and there's 4 different types. Type 1, 2, and 3 are dependent on are independent of insulin. And I've created a table to show you exactly where these transporters will be located. GLUT1 is in the blood-brain barrier, GLUT2 is in the liver, GLUT3 is in the neuron, and 1, 2, and 3 are in beta cells. So all of those I just mentioned do not need insulin. So when glucose is present, glucose will bind to that transporter and immediately be carried into the cytoplasm. Now the one that we're going to discuss extensively is GLUT4. It requires insulin. So that is in the muscle. So let me quickly summarize how this works. So insulin must be present for GLUT4 to work. Insulin is a protein. Insulin is the key. It will bind to the insulin receptor. If this insulin receptor complex forms, then a storage form of GLUT4 is going to translocate into the membrane. And now it's going to be bound to the membrane. So the picture, you see the high glucose on the outside, it cannot move inside until the GLUT4 is bound to the membrane. And this can only happen if the key is present. So as you can see, insulin is very important. It is the key. Insulin was first discovered in 1916, and it was sequenced by the 50s. Insulin comes from the insulin gene. The insulin gene is on chromosome 11 at a specific region called P13. Notice from the image that the first thing you're going to make from that insulin gene is the messenger RNA for proinsulin. So proinsulin is going to be made. This is not the functional form. That is the key. Proinsulin has 3 fragments, and it has the weight of 9,000 Daltons. The 3 fragments are labeled A, B, and C. The C domain must be cut out of this proinsulin in order to activate it. This cleavage occurs by a trypsin-like enzyme. It is going to cut 30 to 35 amino acids out of this 3-fragment peptide, therefore creating insulin, a functional insulin molecule. This functional insulin molecule is composed of 2 fragments, and it is going to have the weight of about 60 Daltons. If we look further at insulin, it is composed of 2 peptides, so they call it a heterodimer. Those 2 peptides are peptide A and peptide B. Peptide A is composed of about 21 amino acids. Peptide B is composed of 30 amino acids, and I've labeled it in the picture to the right. Now, if any of those amino acids are deleted or changed, then the key might be the wrong key. It might not work. So this is insulin and how insulin works. So in summary, insulin is going to open the door to let glucose in. How does it do it? It binds to the receptor. It makes the storage GLUT4 translocate into a membrane-bound GLUT4 form. And then now glucose can be carried into the cytoplasm where it will make the 36 to 38 ATP. This is the normal physiological function of insulin. Now, what happens in the abnormal state? In the abnormal state, insulin is not present, or the receptor doesn't recognize insulin. This takes us back to that first concept map. Type 1, there's no insulin, whereas type 2, the receptor is messed up. The receptor insulin interaction is somehow modified and not working. Either case, you're going to have increased sugar in the blood, which is called hyperglycemia. This increased sugar ends up seeping out from the blood into the urine. And then the urine is going to be contaminated with glucose, a process called glycosuria, sugar in the urine. Now, this is how they named this syndrome, diabetes, a siphoning, the excess urination, the siphoning of the sweet. So the excess P, the excess water comes from the blood, it goes into the urine, and inside the urine you have the sugar. So yes, physicians in ancient time would test for the presence of diabetes mellitus by tasting the urine. Now we don't have to taste the urine. We can use a point of care kit that you can take home, pee in a cup, and stick a dipstick in there. So now we know what diabetes mellitus is. And it's been around for a long time. The ancient Greeks, Indians, and Egyptians first discovered the sweetness of urine a long time ago. Then 250 to 300 BC, they actually coined the name diabetes. So now let's look at the abnormal state. What happens when that insulin is not present? What happens when the insulin receptor binding is inhibited for whatever reason? If those abnormal states persist, glucose is going to be stuck outside of the cell membrane. Therefore, you're going to have elevated sugar outside, a process called hyper above glycemia. Hyperglycemia is high glucose outside of the cell. That is what is wrong. Those patients have diabetes mellitus. And again, there's two types that we'll discuss briefly, type 1 and type 2, but there's also other types such as gestational diabetes, which affects pregnant women around 24 to 28 weeks. And we have these other cases that I'm going to show you. These are some other types of diabetes. You have a genetic component that can cause diabetes. We have exocrine, endocrinopathies. Chemicals can somehow destroy cells of the pancreas, causing diabetes, and infections. Viral infections can cause it also. Diabetes is the topic of the day, but it is not the number one cause of mortality in the U.S. Heart disease is. However, diabetes is number 7, and it kills about 100,000 people a year. So let's not stay on mortality, let's look at morbidity. So, out of 330 million people in the United States, 10% of them have this sickness. So they have the morbidities. And we're going to talk about some of these morbidities later, the sickness. So that means 37 million Americans are sick with diabetes. Now, out of that 37 million, I drew a pie chart to help you understand how many people are sick. So in this pie to the left, we have the blue portion that's 90%. That's the normal population of the US. The abnormal population is 10%. Those individuals have the sickness. They have diabetes mellitus. So let's take that orange slice and move it over to the right. Now, that is out of those 37 million, 90% of them have type 2 diabetes. Out of that pie, let's take 10% slice out. Out of that 10%, some of them have type 1, some of them have genetic abnormalities, some of them have gestational, some have exocrine and infections and so on. Again, we're only going to talk about type 1, and that represents 5% of the overall cases of diabetes mellitus. We'll skip over that one. This is an interesting slide. It helps you to see the health disparity in reference to certain diseases. So to the right, we're looking at the U.S. ethnic distribution based on the U.S. Census report. Whereas to the left, we're looking at the ethnic distribution of diabetes mellitus. So I highlighted in red the health disparity, where the American Indian, if we look to the right, makes up 1.3% of the population, the U.S. population. However, out of American Indians, 33% of them have diabetes mellitus. Let's look at another one. To the right, Asian Americans make up 6% of the U.S. population, which we move to the left, 8.4% of Asian Americans have diabetes mellitus. So you can see the health disparity if you compare American Indians, Asian Americans to white Americans. White Americans make up 58%. However, only 7% of white Americans have diabetes mellitus. So these morbidities cost money. So the U.S. annual medical cost for diabetes is $327 billion. Now out of that value, $237 billion is direct medical costs, and about $90 billion is low productivity. You can't go to work, so you don't get paid. So total, that's $327 billion that diabetes is costing us. Now on the individual level, so it's going to cost you about $16,000 a year in medical costs. Just insulin alone for an individual costs about $6,000. And remember, it's only a heterodimer with two peptides. So let's specifically dive into just type 1 diabetes mellitus. It is an autoimmune disorder where your immune system is going to attack beta cells of the pancreas. And if you look at the picture below, the beta cells are in the pancreas and they produce insulin. So type 1 is not associated with obesity, whereas type 2 is associated with obesity. This means if you are overweight, you're most likely going to get diabetes type 2. It doesn't have anything to do with type 1. Type 1 is more genetic related. Now, who has type 1 can be anybody, but it typically affects children around age 2, 4, 6, 10, and 14. So this is what I mentioned before, where diabetes type 1 has a genetic component. So etiology is what actually causes this immune response to destroy those beta cells. So type 1 can be further separated into type 1A and type 1B. Type 1A can be further separated into polygenetic, monogenetic, and LATA. So let's just look at the first two. Polygenetic. This means you have two defects, two genes, and the gene is at a location. So two locations are messed up, two or more. So that's polygenic. Whereas monogenic, only one location is messed up. So what are we talking about location? If you look down to the bottom left picture, I have what is called the major histocompatibility complex. Remember, that is the actual fingerprint of the cell. So that's why I have a little fingerprint over there to the far right. So every cell in your body has this molecular fingerprint. And if something changes in that fingerprint, your immune system immediately identifies it as foreign, and your immune system is going to try to destroy it. So the cells in the body have different fingerprints. We have the MHC fingerprint and we have the HLA fingerprint. If any of those fingerprints are incorrect, then this is the pathogenesis of what's going to happen. Your T lymphocyte is going to infiltrate the islets of the pancreas and target those cells that have those polygenic changes, that have those monogenic change. So the T helper cell is going to release a chemical messenger called a cytokine that is going to stimulate the T cytotoxic cell to destroy the beta cells. And if the beta cells are destroyed, you no longer will produce insulin. So that is pathogenesis. How did the disease develop? It started because his fingerprint was wrong. We'll skip over clinical manifestations. Let's look at metabolic changes. As the sugar level inside the cell decreases. Remember, if insulin isn't working, that means glucose isn't going inside. So that means the sugar level inside is low. Therefore, the cell is going to have to use, it's going to have to catabolize fat and proteins. So fat catabolism starts in adipose tissue. And in the adipose tissue, we're going to first break down the triglyceride, if you look at the right picture, into a fatty acid. This fatty acid then enters the liver, where the liver is going to convert the fatty acid into a ketone. This ketone is going to be the source of energy for those cells because glucose is not present. So the fatty acid will make ketones, and the ketones are listed in the picture. We have three types. If you look at the picture to the right, it shows you how the fatty acid is converted to acetyl-CoA, and then you know that acetyl-CoA can be used in the Krebs cycle to make energy, or it can be used to make ketone bodies. We're going to just focus on the ketone bodies. So because glucose is low, our body is increasing the production of ketone bodies. Some of the ketone bodies are acidic in nature. So we're just going to focus on acetone. It is an acidic ketone, and we're producing a lot of it because no glucose is present for the cell to utilize. So by the excess ketone bodies that we're producing, we're going to create a disorder called diabetic ketoacidosis. The increased ketone bodies would then lead to metabolic acidosis. Remember, the acetone is the acidic ketone. So it has created two different things, DKA and now metabolic acidosis. So now that we have uh, an acidic blood fluid, we have uh, decreased the pH of the blood fluid or the body fluid. Now we have to kind of counterbalance that by using the blood buffer system. So I put the actual chemical equation to remind you of that blood buffer system. So because the pH is so low in the body fluid, bicarbonate is going to step out of the shadow and tie up that extra hydrogen. If it grabs hydrogen out of the body fluid, it's going to then offset the pH, rising it back up to closer to physiological normal, which is 7.3 something for the blood. So now you see what metabolic acidosis is. You're going to have a decrease of the sodium bicarbonate because it is tying up the excess hydrogen, making carbonic acid. This metabolic acidosis is going to ultimately lead to respiratory compensation. You're going to now start breathing faster. You're going to start breathing deeper because you have metabolic acidosis. And the increased breathing, if someone is standing beside you, they'll be able to smell a sweetness in your breath. This is called the acetone breath. That increased breathing is going to increase carbon dioxide. As carbon dioxide increases, you look at the equation I drew. As you increase carbon dioxide, it's going to bind with water to create carbonic acid. Carbonic acid is going to keep driving the pH down further. This is now called respiratory acidosis. So all of this was created because of the ketones. The ketones that were produced because you did not have enough glucose inside of the cell. So these increased ketone bodies will eventually be excreted out of the urine in a process called ketonuria. Ketones are a solute, and they're in the urine where they're not supposed to be. So what they're going to do is they're going to recruit water. So as you increase solute, you're going to increase water to try to decrease, or that's going to try to dilute the solute. So as you increase water to the urine, you're going to pee even more. All right, so all of that loss of water is called hypovolemia. So if the ketones are in the blood, if you have high solute called ketones in the blood, water is going to follow also. So you're going to lose water from the cell and it's going to go into the blood. And then the ketones ends up in the urine and the water follows. So you can see how you can have a total body loss of water. The last thing of this slide is look at the picture to the right. You can also test for the presence of ketones by using a point of care at-home test. That's nothing more than a dipstick. So now we're talking about testing for the presence of hyperglycemia, or the test to see if somebody is diabetic. So the World Health Organization has a standard for the values that we're supposed to use. So in a fasting state, this is the person who hasn't eaten in 8 to 12 hours, they should have a blood pH, a blood sugar concentration that is above 126. If they have that above, then they are diabetic. If you want to test after you've eaten, you would look for the value of 200 milligrams per deciliter. So if you're below that, you're not diabetic. Anything above that, you are diabetic. So the American Diabetic Association suggests treatment. And it suggests these treatments: nutrition, watch what you eat, and medication, exercise, and hygienic practices. So do, for the nutritional aspect, what we're going to do is we're going to look at diet, meal pattern, and timing, and caloric consumption. Medication, let's look at the pharmacological agents that we would use just for type 1 diabetes. It would be something like insulin. So the insulin has different variations. We have a fast-acting insulin. We have a short-acting insulin that might only last a few minutes. We have an intermediate-acting insulin that might last for a couple hours. And we have a long-acting insulin. So there's different types of insulin. And some of them are injectables, and some of them are powders that you can inhale, as illustrated by the lady in the image to the left. The exercises can have a double-edged sword. Exercises can decrease insulin requirement, which is the good thing. But exercise can also create hypoglycemia, where the body has not enough glucose at all, and that is a bad thing. So let's spend a quick second talking about hypoglycemia. So hyperglycemia is too much sugar in the blood. Hypoglycemia is not enough glucose in the blood. So anything below 70 milligrams per deciliter is too low. And people that have type 1 diabetes, they typically experience 1 or 2 episodes per week. And these episodes would include sweating, paleness, hunger, fatigue, anxiety, rapid heart rate, and so on. So what is the etiology of a person having hypoglycemia? Well, the only one we'll talk about is inappropriate insulin. So maybe they are injecting insulin and they injected too much, or they have not the right dose of insulin. If they have too much insulin, that means too many glucose GLUT4 transporters are moving glucose in, and there's no glucose left. So when a glucose deficit is achieved, you can cause brain damage, because neuronal tissue has to have a constant supply of glucose or you can die. So what immediately happens when you have a hypoglycemic state is the sympathetic nervous system has to counteract the hypoglycemia. And what it will do is it would immediately produce glucagon from the alpha cells of the pancreas. So the alpha cells of the pancreas are going to increase this glucagon. This is another hormone. It is just the opposite of insulin. So if insulin decreases blood sugar, glucagon is going to increase blood sugar. So it's like the antagonist. It's on the seesaw of homeostasis. How does glucagon work? Is it is going to increase glucose production. How? In 2 ways. One method, it can take glycogen and break it down into glucose, a process called glycogen lysis. Or it can take other molecules that's not sugars, such as glycerol from lipids or amino acids, and we can convert those non-sugar molecules into glucose. So that's what glucagon is going to do. So that ends diabetes type 1. What I'm going to now talk about is clinical manifestations. And there's 2 ways I can teach this. I can teach it based on a concept map. This looks messy, but typically I would start and I would draw it in the classroom. But I'm going to just do it the traditional way because I'm kind of pressed for time. So clinical manifestations, we have 1, acute hyperglycemia. Now, what is acute hyperglycemia and how is it caused? Well, we know that it is unexpected and it comes suddenly. And it comes because of the patient has altered their nutrition. They're on some special diet, the caveman diet, the paleo diet, the Kim Kardashian diet. So some alteration in nutrition has caused them to have an increase of glucose in their bloodstream, or they're inactive, or a combination of all of them can create an acute episode of hyperglycemia. If you have hyperglycemia, acute hyperglycemia, these are the signs and symptoms: polydipsia, extreme thirst; polyuria, extreme urination; polyphagia, extreme hunger. Another type of clinical manifestation is chronic hyperglycemia. Now, this one isn't sudden. This one is always present. It's like uh, always there. It's always lingering in the darkness. But if you have chronic hyperglycemia, it is going to affect the vascular system. You're going to have vascular complications. Now, we can separate this into big vessels and little vessels. So the first one we'll look at is big vessels, macro angiopathy. In this case, the big vessels are going to become clogged, or they're going to have a buildup. They're going to be hardened and thickened, and it's going to form something that's called a plaque. We call this arteriosclerosis. So this arteriosclerosis is going to be located on all of these large vessels. So one type of macroangiopathy affects the heart. It's called the coronary artery disease, CAD. Another one affects the brain. It's called the cerebral vascular complication. It's called CVC. And finally, we have the peripheral vascular disease, where the peripheral vascular tissue is damaged, and the peripheral vascular vessels are in the extremities, the legs and the arms. So we'll skip over that one. Now, the other type of chronic hyperglycemia that involves the vessels is going to be microangiopathy. This is going to damage the small vessels such as capillaries. How it damages it is we're going to have a thickening of the basement membrane that makes the capillaries harder to diffuse gases. This means on those little fingertip cells and those little toe cells, they have to get oxygen too. But if those capillaries aren't diffusing the gases, those cells are going to start to die. Now, I mentioned fingers and toes, but this can happen anywhere. So under microangiopathy, we have nephropathy. So nephropathy affects the kidneys. So the actual cell of the kidneys is a podocyte. This podocyte will experience apoptosis that will create lesions. These lesions are going to damage the membrane of the capillaries. These capillaries are going to become leaky, and these capillaries are in the glomerular capsule. And remember, if you remember your urinary system, this is where the solutes and the water is going to be absorbed out of the Bowman's capsule. So you have your efferent and your afferent blood vessels coming in, and then the ketones are going to be diffused out, right? Then we have the sugar is going to be diffused out because we have too much. So this is where all of that is happening. So if we have these microangiopathy, we have these capillaries rupturing and becoming leaky, we can have proteins end up being present in the urine. A protein, a specific protein is albumin. So again, we can use a point of care test to test for the presence of proteins in the urine also. So the damage to those cells, the podocyte, initially is going to cause what is called first phase nephropathy. First stage nephropathy is going to be when the glomerular flow rate is going to increase. You're going to have more urination. Then eventually, the glomerular filtration rate is going to drop. And then now you're in end stage renal failure. Did you know that 40% of end stage renal failure is directly linked to diabetes, nephropathy? The next one we'll look at affects the eyes, retinopathy. It affects the cell type in the eye called the pericyte. So the pericyte is going to go through apoptosis, and it's going to damage that cell type, which is going to damage the capillaries. In this case, you're going to have these microaneurysms, the bulging of the vessels that are going to occur, and you're going to have these small hemorrhages that will form, that will bleed out. Did you know that retinopathy is going to be the primary cause of blindness in the United States? The last one we'll talk about is also under chronic hyperglycemia. So you cannot control your sugar level and you've had it for years. So you can develop neuropathy. So neuropathy affects about 50% of adults with diabetes. The only one we'll talk about is sensory dysfunction, senses. So the input of the sense is going to be damaged. Why? Because the neuron is damaged. So if the neuron is damaged, then you're going to lack the sensation. So what if this neuron goes to the foot or the lower extremity? You will lose the sensation of the damage. This damage can become infected, and this infection can lead to amputation. So neuropathy is commonly called the stocking and glove syndrome or stocking and glove disease, where it's the extremities that you can't feel, and you end up having these cuts and bruises that get infected, and you eventually have to amputate it. So this concludes my talk. This concept map probably makes more sense to you. So I hope I explained all of this to you, and I look forward to getting your questions now.